So
Ready, ma'am?
warm welcome and a very good evening to all of you. Thanks for being here, sparing the time for this very important event of the day. And what we are going to talk about today is something very important. So this is the FOGSI ICOG Jogi Research Methodology web series. So this is the first of 12-part web series that we plan to have in the next 1 year. And we today are focusing on the study designs. And we are extremely happy. It gives us immense confidence and a feeling of togetherness to have the entire heavyweight celebrities, the stalwarts, and the experienced people of FOGSI, ICOG, and the Jogi with us supporting this endeavor. And it also emphasizes the focus that and the commitment that FOGSI has today in the direction of the clinical research. So we have Dr. Rishikesh Pai, who is the FOGSI President 22-23, Dr. Lakshmi Srikhande, who is the Chairperson of ICOG 22-23. I must say she has really ensured and driven this program. So thank you so much, Dr. Lakshmi. Dr. Parag Binewale, who is the Vice Chairperson of ICOG, Dr. Madhuri Patel, she is the Secretary General of FOGSI. We have Dr. Suvarna Kadilkar, who is the Deputy Secretary General of FOGSI 21-23. Dr. Ashok Kumar, who is the Director Professor and Head of in the Department of Atal Bihari Obs and Gynae in the Ram Manohar Lohia Hospital, and he is also the Secretary of ICOG for the year. And we have Dr. Geeta Balsarkar, who is the Editor-in-Chief of Jogi. And now I invite Dr. Lakshmi Srikhande to please address and give us a welcome address for the program today. Thank you so much.
Thank you. Thank you so much, Radhika. And very good evening to one and all. It's a pleasure to welcome you all for our first activity of this tenure, and we are happy to start with FOGSI ICOG Jogi Research Methodology web series. I welcome our dynamic president, Dr. Rishikesh Pai. He has conveyed his best wishes. Dr. Radhika, yeah. He has conveyed his best wishes as he is unable to log in because he is traveling. I welcome Secretary General of FOGSI, Dr. Madhuri Patel. Thank you, Madhuri, for being here with us in spite of your hectic schedule. I also welcome our Vice Chair, Dr. Parag Binewale, ICOG Secretary, Dr. Ashok Kumar, Editor-in-Chief of Jogi, Dr. Geeta Balsarkar, and Editor Emeritus, Dr. Suvarna Kadilkar. When I was thinking of this web series, I just thought of Dr. Radhika. Dr. Radhika, thank you so much. You are really doing justice the way you have planned these 12 modules spreading over 1 year, where you will be teaching research from basics to all the PGs, clinicians, and consultants. And I also welcome the coordinators, Dr. Vaishali, Dr. Ranjana, all the speakers, two great speakers who are there, Dr. Archana, Dr. Tanu, and the chairpersons, Dr. Bharti, Dr. Jyotsna, Dr. Vani Aditya, Dr. Madhu Gupta, Dr. Renuka Malik, and Dr. Rimpi Singla. So why we have started this web series? First and foremost, because you all will agree with me that every clinician has to be a researcher. But when we say this, the question comes from where to start. So here we are here to hand-holding of all the concerned who are interested in writing articles. We really need quality articles, and who wants to present papers in the conference. This research methodology web series will be of great help to you, and Dr. Radhika has already elaborated her plan of action for 12 months to come. Apart from this research methodology web series, Dr. Radhika, please stop screen sharing. I would just like to show the activities. Apart from this research methodology web series, ICOG is also planning a lot many activities during this tenure. And this is the team which I have already introduced. These are our various other programs where I would like to urge each and everyone to log in for our Gurukul series, for our journal club, for our Sankalp webinar series, for our master classes, our FOGSI ICOG tutorials, and our ICOG weekend online certificate courses. I also wish to have many more fellows in the fold of our Indian college. For more details, please visit our website icogonline.org, and you will get all the information related to the various courses, various training programs which we all are running. So without taking much of your time, I say and again urge you all to join ICOG as it is your college. So make it more strong, give your active inputs and actively participate in all our activities. So thank you so much for joining us. And here I would like to invite our dynamic Secretary General of FOGSI. She is the first lady who is holding this post to give us her pearls of wisdom and blessings on this first module. Dr. Madhuri, please.
Thank you, Dr. Lakshmi, for your kind and warm words. Can you hear me, Lakshmi?
Yes, yes, we can hear you.
Yeah, so I'm traveling, so that's why there may be some disturbances. So respected our president, most dynamic president, Dr. Rishikesh Pai, and our another most dynamic lady, Dr. Lakshmi Srikhande, ICOG chair, Dr. Parag Binewale, vice chair ICOG, and we all are very good friends. And then Dr. Ashok Kumar, secretary of ICOG, Dr. Geeta Balsarkar, editor-in-chief, Dr. Suvarna Khadilkar, Deputy Secretary General, and the editor emeritus. We all are closely related, not related, but very thick friends. And we have worked together and we are working together since last 20 years. And of course, Dr. Radhika and that is a coordinator, then Dr. Vaishali Kode, Dr. Ranjana Sinha, and all the speakers, as Lakshmi has pointed out, the very good speakers and chairperson, and all my dear members who have joined over here for today's course, this web series, and very good evening to all of you. At the outset, I would like to thank Dr. Lakshmi and team and our journal team and Dr. Rishikesh Pai for giving me this opportunity. As I have, as a FOGSI Secretary General, I take the opportunity to tell you that the FOGSI is most vibrant, prestigious, and one of the largest OBGY professional organization in the world, with 263 member bodies and 38,000 plus members committed to women's health. And of course, FOGSI has vision, and their visions are, that we protect and support the practitioner of OBGY in India. Then we believe in disseminating the knowledge. Research, especially research also comes into it. That is FOGSI, one of the vision. And of course, we sought to advocate women's reproductive and sexual rights. And of course, our primary mission is reduction in maternal mortality rate. Now, Lakshmi, you have started this series. I'm very happy. And I have seen last year, Dr. Meg, and before that, you all are very active as an ICOG chair with your team. And, our mission that our students, our, consultant, when they apply for the college for their, position, the paper publication is very, very important. What you present in the conferences is not that important, but your publications are very, very important. On there, the points are there. So you should know the research methodology thoroughly. So whenever you apply in a good journal, your paper should not be rejected. And when you apply or when your paper gets published in the authentic or the prestigious journal, it really carries a good weight. So this is a good platform for all the students and the consultant to go through this web series, and you will definitely find it useful. We all have done this from the journal also. We are doing PICSEC program. So we have to support and we have to train our people. And what we have realized, there are more and more papers are coming in the journal of a
You got muted, Madhuri. You got muted.
PICSEC program. We have this research methodology. And therefore, I congratulate Lakshmi, Dr. Parag, Dr. Ashok Kumar, Dr. Geeta, Suvarna, and all the coordinator, Dr. Radhika, and all for the, this most apt webinar. And I wish them best luck. Thank you, Lakshmi, for inviting me and giving me this opportunity. Thank you very much.
Thank you, Madhuri. Thanks a ton for your pearls of wisdom. Yes, back to Radhika.
Yeah, thank you so much. That's been extremely encouraging. I invite now Dr. Ashok to kindly deliver a vote of thanks, please.
Good evening. Am I audible?
Yes, yes, you are audible.
Yes.
Yeah. Good evening, Dr. H.D. Pai, President FOGSI, Dr. Madhuri Patel, Secretary General FOGSI, Dr. Lakshmi Srikhande, Chairman ICOG, Dr. Parag Binimala, Vice Chair ICOG, Dr. Radhika for this webinar, and our all faculty and the chairpersons of this webinar today, and all the participants. I sincerely thanks for all your participation and encouragement. And it is the vision of Dr. H.D. Pai and Dr. Lakshmi Srikhande, under which we all are working, as ICOG is the academic wing of FOGSI, and in Jogi, the journal of FOGSI, which is there, we both are working towards establishing, encouraging all the members to work for new research and everything. So this is the way to provide support to all of you, and we are thankful that under the dynamic leadership of FOGSI President Dr. Pai, we are able to do this, and we hope in the few courses also you all will be able to join us. So we just from the FOGSI, ICOG and Jogi, I take this opportunity and I'm honored to propose a vote of thanks to all of you for your participation and all your saying good words and encouragement to all of us. Thank you very much.
And I would like to extend my sincere gratitude to Dr. Geeta Balsarkar and Dr. Suvarna Khadilkar for providing their inputs and encouragement in starting this web series. They both have logged in here. So thank you so much, Geeta, Suvarna, for all support you have provided. Thank you.
Thank you. So I echo those words, Dr. Lakshmi. Thank you so much, Dr. Suvarna and Dr. Geeta. You have been great advisors, and we have been together in planning this program. So thank you once again. So now we go on to the program. So I am very happy to introduce my two coordinators. Incidentally, the slides are not moving, Jignesh. Yeah. So let me introduce myself first. So, so I work as a senior consultant Obs Gynae at the University College of Medical Sciences and GTB Hospital. So my special interests are in evidence-based healthcare and guideline development. So I've been associated with the Cochrane collaboration and the Campbell for over 20 years. And currently I'm enrolled in the International Guideline Development and Credentialing and Certification in Guide program of McMaster University at Toronto. And I am the first Indian to be chosen for that training. So I am extremely proud and happy to be doing so. I am at level 3 already. And then, rest of my, some smaller achievements are there. I am happy to also introduce Dr. Ranjana Sinha. She's a senior consultant at Gynae Clinic at Patna. She was a former head of Gynae in the Railway Hospital at East Central Railway, Patna, executive member of ISOPAR, former joint secretary ISOPAR, co-chairperson of Practical Obstetric Committee POGS, and received national award for outstanding service in the Indian Railways by Government of India. And we also have with us Dr. Vaishali Kode Naik, who is the professor and head of MIMER Medical College at Pune, and she's a consultant in critical care obstetrics at Ruby Hall. She's a fellow maternal and fetal medicine at NUS Singapore, and she has contributed to many books and journals, and she's got a lot of accolades to her credit. So, with that said, I just wanted to add one more word of regarding the program in the next 12 programs. So, here the difference between any other training program and this is that today, we have, other than the primary research, we have secondary research. So, we are not only going to talk about and focus on the basics of primary research, we would be introducing the audience to also the systematic review, which is a secondary research, and how guidelines need to be developed. So I think that's very important for our country, and FOGSI with its commitment, and Dr. Lakshmi from ICOG would certainly agree with me that the time is now just right for us to go in that direction. So with those words said, I hand over the mic, Dr. Vishali, please.
Thank you, ma'am. Thank you for those kind words. And the dignitaries from FOGSI, Yogi, and ICOG.
Dr. Vaishali, you need to be a little louder. Your voice is just come closer to the mic, please.
Okay. So thank you so much, ma'am, for the introduction. And all the dignitaries from FOGSI, Yogi, and ICOG. We are grateful that you have given us this opportunity. And it's really, we are enjoying arranging these web series. This is a web series on research methodology, and the first session is on study design. And in first session of today, we will have descriptive study designs discussed, and for which we have very eminent chairperson. And we are very fortunate to welcome Dr. Bharti Maheshwari. Madam is Professor and Head Department of OBGYN and IVF at Muzaffarnagar Medical College. She was chairperson FOGSI MCP Committee 2018 to 20. She has done fellowship in medical education by MCI, governing council member of ICOG, secretary UPCOG, president Mirror of the Gynecology Society, and she has authored many books and published a lot of papers. So we are really happy to have you, ma'am, as chairperson. Next slide, please. Then we have Professor and Head of Critical Care Obstetrics from Safdarjung Hospital, Delhi, Dr. Jyotsna Suri. Adam was Vice President AOG 2021-22, National Corresponding Editor of Yogi at 2021-24, present on this course. Chairperson State Fatherhood Committee, AOG for 2019-21. Chairperson Multidisciplinary Committee, AOG for 2016 to 18. And Madam has edited and co-authored books on practical approach to critical care in obstetrics. And she also has been awarded the Dawn Prize for Best Paper in the ICOG. And she's the recipient of APJ Abdul Kalam Appreciation Award. So, Madam, we welcome you. And Dr. Mani is not there, so I hand over the session to you for the first talk by Dr. Archana R. Kindly introduce the talk. Dr. Bharti, ma'am?
Yeah. Can you hear me? Yes.
You're audible.
Can you hear me?
Yeah, we can.
Yeah, okay. So, first of all, good evening, everyone. And I would like to congratulate and thank whole FOGSI and ICOG team, Dr. Rishikesh Pai, Dr. Madhuri Patil, Dr. Apni Lakshmi Shrikhande Madam, that she has addressed so well. And congratulations on her this ICOG's research methodology first web series. And of course, Dr. Parag Biniwale and Dr. Ashok, as well as today's organizing team whole, Dr. Radhika, thank you. And regarding this workshop or this webinar, I would just like to share that we actually need it. And research, as we all are saying, that it should be a part of our clinicians. Now NMC, MCI already has done this compulsory for all residents. So in future, all practitioners, they will be also trained in some bit, as well as faculty also. And regarding this today's first topic, that as you have told about the observational study, that we should all know about these things, what are the different type of studies and how we can use it in different subjects and the protocols. So I hope that in the first session, Dr. Archana, they are going to tell us about, in very simple way, specific things about the observational studies. So to Dr. Archana, And Dr. Archana, if some other chairperson she would like to introduce, Dr. Josna, you would like to introduce Dr. Archana?
Yeah, thank you, Dr.
Dr. Archana, she is the Deputy Director Scientist at the ICMR, and she is got many prizes for the research work as well as for the academic input. And she is the recipient of IAPSM Ford Foundation Epidemiology grant, and as well as she is published over 40 articles in the national and international journal. And she has been a resource person for the special workshop on the research methodology. So welcome to Dr. Archana, and we are here eagerly waiting to hear your topic. Dr. Archana.
Thank you, respected chairperson and
So, Dr.
vice
Archana,
chairperson.
I'll stop sharing. You please start yours.
Yeah, sure, ma'am. Thank you. And I hope my slides are visible and I'm audible.
Yes to both.
Very clear.
Yeah, thank you so much. And respected chairperson, vice chairperson, at the outset, first, I would like to thank everyone for giving me this opportunity from FOGSI, ICOG, and JOGI. And without much ado, I'll just quickly go to the topic proper. So today we're going to be discussing about observational study designs. So our focus will be, as I know that this is a mixed audience, we have got postgraduates, we have got early career faculty, we have got some senior faculty as well. So I'll try to keep it very simple, being the first session. The primary objectives of this session would be that everyone who's attending the session at least is able to know what are the major observational epidemiological study designs and when to use a descriptive study design and when to use an analytical study design, and also to just make you aware of some of the key strengths and weaknesses of each design. So to begin with, and to make it interactive, I've kept a few questions. You can always, write your answers in the chat box. So before we go into observational study design, there are two terms that I'm going to constantly use throughout the lecture. One is called as outcome variable, and the other is called exposure variable. I'm sure some of you have heard about it, some of you have not heard about it. But my question to you is, in a setting like, does the incidence of preterm labor differ among women with multiple pregnancies who have underwent early or late fetal reduction? Suppose if this is the research question, could I have some quick access answers in the chat box as to what is the outcome variable that we are looking at? So I'm looking at the chat box. My question to you is, like, if there are women with multiple pregnancies who undergo early and some may undergo late, will there be a difference in the incidence of preterm labor between these two groups? If this is a research question of, let's say, a hypothetical researcher, what could be some of the, we're getting some answers, very good. Some people are typing preterm labor, excellent. So the key outcome variable that we are looking at is preterm labor. So what do we mean by outcome variable? A variable is some characteristic of the study participant, and by the term variable, it means that different study participants would have different outcomes or different values for these variables. If it is a key focus outcome of your study, then we call that as an outcome variable. And similarly, could you also enter into the chat box what are the key exposures of interest that we are interested in this research question? We have some answers in the chat box. I'm looking at the chat box. Quickly, you can write whatever you think. Excellent. Someone has written early and late fetal reduction. Excellent. Excellent, Dr. Kranti. So what do you mean by exposure of interest? So I'm sure you are the subject experts. When you do early versus late fetal reduction, the incidence of preterm labor in both these interventions is going to be different. So these, if you expose an individual to an early fetal reduction, a woman with multiple pregnancy, then her risk for preterm labor would be different if you expose a person to late fetal reduction. So here the exposure of interest is whether the person has underwent early or late fetal reduction. So I think, so some of the other terms for outcome variables are, some people call them dependent variables, especially your statistician. Some people call them response variables. Some of the exposure variables are, some of the statisticians call them as independent variables. Some of them say these as predictor variables. But throughout my lecture, I will maintain them as outcome and exposure variable. So coming to the topic proper, today we're going to discuss about observational epidemiological study designs. Before we go to them, we need to know what are the major types of epidemiological studies. So there are two major types of epidemiological studies. One is the observational studies that we are going to cover today. The other group is called interventional studies, I'm sure, which will be covered by somebody later. So I'm sure I'm getting more chat responses, but I'll not be able to monitor chat now. So I'll take up questions in the end. So what is the key difference between observational and interventional studies? Observational studies are those studies where the researcher or the investigator merely observes. He does not do anything actively other than just observing the study participants and documenting certain exposures and documenting certain outcomes. So observational studies are ones where we observe the natural course of events. Whereas in contrast, experimental studies or interventional studies are those studies where the researcher or investigator actively assigns individuals to two groups. One group can have an intervention A, the other group can have an intervention B, and then looks for certain outcomes of interest. So when the investigator intervenes and determines who will receive what intervention or who will go to which arm of exposure, then those studies are called as interventional studies. So the simple question that an early career researcher should ask whenever you have a research question is to know what type of study design you are reading through when you're reading literature is, has the investigator assigned the exposure? If the answer to this question is yes, then you're dealing with interventional studies. And they could be of multiple types, which will be covered later on in the webinar series. If the answer to this question is no, then we are talking about observational studies. So our focus today is observational studies, where the researcher follows the study participants and does not intervene and looks at the natural course of events. See, observational studies are also of different types. The two major types of observational studies are descriptive observational studies and analytical observational studies. Through the course of this lecture, I'll try and explain to you what is the difference. Just as a prelude, I'm showing that there are different types of descriptive studies and there are different types of analytical studies. And this list is not exhaustive. I've tried to list some of the common studies which are used in the field of obstetrics and gynecology. So what are these descriptive studies? Descriptive studies, as I said earlier, are things which try and describe who are the people with disease, who are these individuals, what age group do they belong to, what comorbidities do they have, what is their gravida or para, and where are these individuals coming from, and has the disease burden changed over time, or when is the person presenting to you in the clinic. So descriptive studies merely describe the natural course of events. So for example, this is a study from which is published recently in Clinical Epidemiology and Global Health, where the authors have tried to talk about prevalence and determinants of primary infertility in India. Now they have analyzed this data from the nationwide representative NFHS survey. So as I said, descriptive studies should describe either burden. So they have said primary infertility is there and the burden is about 17 per 1,000 married women. Who are the ones who are usually having primary infertility? Which age group do they belong to? what is their socioeconomic status, whether these are individuals with a higher BMI, whether they have comorbidities like impaired glucose tolerance, or whether they have something like diabetes, etc. And where is the burden higher in India, whether it is in the north, south, east, west, and has it increased over time? So descriptive studies are studies which describe certain diseases in terms of what is their burden, who are the ones who are affected, where are they, and has it changed over time? So in descriptive, as I said, there are two common types of studies which gynecologists and obstetricians use. One is the case report and case series, and the other one is cross-sectional study. So first, let's look at case report and case series. Now, this is an example of a case report which is published recently in the BMJ case reports. It talks about a case of urinary tract obstruction where the lady is presenting in the second trimester and she's got an incarcerated gravid uterus. Now, how does this fit as a descriptive epidemiological study? This particular report tells us who is the pregnant woman, what is her characteristic, what is her gravida para, when did she report to the clinic, what were the symptoms and signs that she presented with, what investigations were done to come to a diagnosis, and what was the treatment that she was given. So a case report is something that describes the event, what happened to a particular case who came to your clinic. So why do we usually do case reports, or when do you usually write up a case report? Usually case reports or case series are written when you have a unique presentation of a known disease or condition, or you want to report to your peers about the occurrence of a rare condition which was presented to you in your clinic or in your hospital, or you want to share with your peer group about some newer techniques which helped you diagnose a case earlier, or you want to talk about some innovative way in which this case was managed better, which could help your peers and thereby improve the scientific knowledge in that area. So these are the times when you as an early career researcher might want to write up a case report. So if you find that there is an interesting, unique presentation which has come to your clinic, your OPD, your emergency, then you may want to write it up. So usually case reports also help in generating some hypothesis. Maybe you'll find some new thing which you want to investigate further, which you want to analyze further, and these reports or series can help you in this. So a good case report should have a clear focus. You should know what you are wanting to share with the other community of obstetricians and gynecologists. Do you want to talk about a rare presentation of a known disease? Or do you want to talk about what was unique in the presentation? Do you want to talk about how quickly you investigated? Or do you want to share with the best practices that you used for management, which resulted in a good outcome? So you should have a clear focus, and you should say why you're writing up this report and what particular observation is important. The other thing that I want to share with you is, whenever you're writing up a case report, as an early career researcher, you might be looking for some guidelines. So there is something called as the CARE guidelines, and I'm leaving you with this if you type BMJ case reports CARE guidelines, you will be guided to this document. And this is a very good read for an early career researcher to know what is the consensus guidelines on how to write a case report. So till now we have discussed descriptive study. What is a descriptive epidemiological study? It is a study where we are trying to just merely describe a condition or maybe describe a case. We'll move to what is descriptive cross-sectional study. So a cross-sectional study is when you're interested in identifying the burden of a particular condition. So what do? Usually you do a survey among a group of individuals and try to identify how many of those, what is the frequency of individuals with your outcome of interest. So that's why we in epidemiologists usually call this as a snapshot study. It gives you a snapshot information. And in this type of study, you meet your study participants only once. you collect information both about the exposure of interest as well as the outcome of interest at the same time point. So some epidemiologists also call cross-sectional studies as prevalence studies because we're trying to estimate the burden. And cross-sectional studies can both be descriptive as well as analytical. We'll discuss about that as we proceed. So just to give an example, here the authors are trying to do a cross-sectional study to understand what is the burden of PCOD among adolescent and young girls in Mumbai. So if you will look at the abstract, you can see the results section. They have tried to quantify what is the burden of PCOS. It's about 22.5% by a particular criteria, the Rotterdam criteria, and they have described it based on different criteria. They have also said that what are the characteristics of the girls who have PCOD? These are the ones who are more hirsute, who are hypertensive, and who had significantly higher mean insulin levels. So a descriptive epidemiological cross-sectional study tells you burden of a particular condition and also tries to describe who are the people who are having this condition. As opposed to a descriptive study which merely focuses on prevalence, you can also use cross-sectional studies to test some hypotheses. These cross-sectional studies are called as analytical cross-sectional studies, and they examine relationship between an exposure and a disease. So I'll talk more about analytical cross-sectional studies in a minute, but this concludes the key points that I wanted to tell you about what is the case report and what is a descriptive study. So the key takeaway from this is descriptive studies are those studies where you systematically describe a particular situation without actively, documenting any association. So these are describing a particular disease or describing the course of event of a unique case which has come in the form of a case report, or you can do a survey in a particular population trying to understand what is the burden of a particular condition and then trying to describe who are the individuals, where are they, like the study on primary infertility. Moving on to the analytical study designs. So in observational epidemiological study, we have both descriptive and analytical. We have completed the descriptive section. Moving to the analytical section, in the analytical studies, the key studies of interest to you could be analytical cross-sectional study, cohort studies, and case control studies. Let's look at one by one. So what are analytical epidemiological study designs? Analytical studies are those which are trying to see if there is a relationship between an exposure and a disease. Like, do you remember the first question that I asked you? Is the incidence of preterm labor different in the mothers with multiple pregnancy who have undergone early fetal reduction versus the mothers with multiple pregnancy who have undergone late fetal reduction? So basically, you're trying to see if there is a relationship between preterm birth and the timing of fetal reduction in women with multiple pregnancies. So some of the other terms for the exposures which epidemiologists use could be determinants, risk factors, etc. But what I want you to remember is analytical studies are those studies where you want to see if an entity is associated with an outcome. Like if you want to see whether early or late, whether the timing of fetal reduction, is it really associated with preterm birth, the number of women who have preterm birth later on in pregnancy. So whenever we see analytical studies, the hallmark of analytical studies is that there is a comparison group. You always have to compare, like for example, in the example that I gave you, you have to compare those women who underwent early fetal reduction vis-a-vis those women who underwent late fetal reduction. So always there is a comparison group so that you know which group has got higher outcome of interest to understand whether there is an association that exists or not. And technically, to test whether actually there is an association that exists or not, we use several statistical techniques, and we call this as hypothesis testing. So at the end of hypothesis testing, we would try to quantify these associations using certain measures of association, which I'll talk to you later. So taking the same example of PCOD, In this particular cross-sectional study, they have gone beyond looking at what is the burden of PCOD. They have gone beyond, describing the adolescent girls with PCOD. Here, they want to know who exactly are the group of individuals and what are those risk factors that are associated with polycystic ovarian syndrome. So in this particular study, they have found that PCOD is associated with obese individuals. It's associated with probably people with higher insulin resistance, etc. So whenever you want to associate a particular exposure with the outcome, then you can, one of the studies that you can do is an analytical cross-sectional study design. Now, in the particular study that I just showed you, to describe the burden, you can say prevalence, but when we want to talk about measure of association, whether there is a relationship between obesity and PCOD, then you will have to look at either prevalence ratio or prevalence odds ratio. Now, as I move forward, I will be talking to you a little bit more about odds ratio, but I'm not going to talk to you in statistical terms. I'm trying to talk to you in more epi terms so that you'll be able to understand. Now, what are some of the strengths of cross-sectional study design? By now, you know that, survey conducting is relatively easy and economical as compared to, doing the other type of study designs, which are analytical, like, a case control or cohort. And cross-sectional studies give important information about who are the individuals who are affected by this particular condition. They are studies which estimate the burden of particular diseases. And they are good first steps to generate some hypothesis, which you can then use other studies to test. And as an epidemiologist, it is always helpful for us to plan health services based on the burden of the condition. But there are a lot of weaknesses in cross-sectional study design. And one of the key weaknesses, you really cannot establish the time sequence of events. The key hallmark of a cross-sectional study is it is a snapshot study design. That means you meet your study participants only once and you collect information both about their BMI as well as whether they have PCOD at the same time. So you really do not know whether if they have been overweight for a longer period of time and whether that has resulted in PCOD, or whether, it's a coincidental, fact that obese people are having PCOD. So in local terms, we call as egg chicken effect. You do not know whether the chicken came first or the egg came first because you're looking at an individual only at one time point. And technically, we call this egg chicken thing as reverse causality, because you really do not know whether the outcome has come as a result of exposure. Another important thing which the cross-sectional studies cannot do is they cannot really talk to you about risk or incidence, because to know risk, you need to follow up a group of people who have the particular exposure and then see if they have an outcome to really say whether they have high risk for the particular condition or not. So with this, I cover analytical cross-sectional study designs, and I've got a question before we move to the next section. So my question to all of you is COVID-19 infection during pregnancy associated with preterm birth? Now, there is an early career researcher who has got this research question in mind. He or she is interested to know whether COVID-19 infection during pregnancy is associated with preterm delivery. Now, can you suggest some study designs that you would use to address this research question if you want to find answers to this research question? Now, I'm looking at the chat box currently. Can we have some quick responses? What type of study designs do you think can try and tell you? Analytical, descriptive, excellent, excellent. Analytical studies, very good, excellent. Analytical, right. So I think we are on the right track. So people are saying that we need to use some analytical study designs in order to answer this research question. Now, two very common analytical research designs that we use are, one is called as case control and the other is called as cohort study design. Now, several of you might have heard like cohort studies are prospective studies, case control are retrospective. prospective, retrospective, all these are very confusing terminologies. Currently, in the standard of reporting is you report how you have done your study rather than describe them by these terms. One of the key things, like as an epidemiologist, for me, what matters is what is the direction of inquiry that you have employed while doing the study design. What does direction of inquiry mean? Do I start with people who have the outcome and look for whether they have been exposed to certain exposures in the past? If I do this, if I start with people who have the outcome and look for exposures, like in my example, COVID-19 infection, if it happens in pregnancy, whether it's associated with preterm delivery, my outcome here is preterm births. And I'm looking at COVID-19 infection during pregnancy as an important exposure. So if I start with outcome and if I look at history of exposure in the past, then this type of studies are called as case control study. So the direction of my inquiry begins with people who have the outcome and I'm trying to look for exposure. If my direction of inquiry begins with exposure and if I look at outcome in the future, then I call that as cohort study design. So if I start with exposure here, in the case COVID-19 infection in pregnancy, and if I follow up the women and look for preterm delivery, then it is a cohort. Again, I'll reiterate this in the next few slides. So what is a case control study design is, you start with outcome, look for exposure in the past. So if you apply that to our example, you take at the beginning of a study a group of women with preterm delivery, and these are your cases. And you have another group of women, pregnant women, another group of women with term delivery who are your controls. And you look in both the cases and controls whether they have had COVID-19 during pregnancy. So if you find that the group of women who have had preterm delivery, a higher proportion of them have had COVID-19 during the pregnancy as compared to the women who have had term delivery, then automatically you can understand that there seems to be an association. Of course, then we do need to look at the odds ratio. We need to do some statistical tests. Those are other things, but in your mind, you know that at least you're forming a hypothesis. And then, of course, you're going to test those hypotheses by looking at the confidence interval of the odds ratio or by statistical tests. So if you want to address these research questions, you can also do a cohort study. Now, how do you do a cohort study for the same research question? You begin with exposure and then you move towards looking for outcome. So you have a group of women who have COVID-19 during the pregnancy, and you take another group of women who do not have COVID-19 infection during pregnancy. So the women who have, they are the ones who are called as the exposed cohort. The women who do not have are the comparison cohort. Through the pregnancy, you give care and then you follow up the women. And once they deliver, you document whether there has been a preterm delivery or not. If you find that the exposed cohort has got a higher number of preterm delivery, then there is an indication of association which you need to further test with odds ratio and which you need to further test using risk ratio, or you need to further test with statistical tests. So case control study design is where you start with outcome and talk about exposure in the past. To pictorially represent, again and again, I'm reiterating because this is a thing that is maximally confusing to early career researchers. What is case control versus what is cohort? So in case control design, you begin with a group of people who are diseased. You begin with a group of people who have PCOD, and then you have a group of adolescents who do not have PCOD, and then probably you go in the past and check whether they have had obesity early on in life. Some of them may have had, some of them may not have had. But those who have had obesity, if that proportion is higher in the group with PCOD, then probably there is an association. So that is how you design a case control study. The key thing is you have to assess exposure and ask history about whether they have had this exposure in the past, not at the same time when you have enrolled the individuals into your study. Because in case control, the exposure is not what the person is having right now, but what the person had in the past, which could have led to occurrence of the disease. So if you want to epidemiologically understand whether there is an association and quantify it, then the measure of association that you need to use is what is called as odds ratio. Now, I'm not going into the details of what is odds. For interested people, if we have time, we can discuss it at the end. But odds ratio is the ratio of what is the odds of exposure among the group with the condition, that is outcome cases, divided by the odds of exposure among the group without the condition, that is controls. So epidemiologists are very fond of this sort of, visually seeing the data. That is, we call this as a 2x2 table. In this particular table, I'm not going into the details, but there is a mathematical calculation that can help you calculate odds ratio. So whenever this odds ratio is more than 1, then usually you know that there is an association between your exposure and the outcome. In our example, that means that preterm deaths, preterm delivery, the odds of individuals with preterm delivery having COVID-19 infection in the past is higher as compared to those who have had a term delivery. So what are some of the advantages of case control study designs? Case control studies are cheaper and they can be done faster than their counterparts, that is the cohort studies. And you can do these studies for rare conditions because you're beginning with the people who have disease. By that, suppose if you want to know what are the factors or what are the risk factors for, let's say, ovarian cancer. Now, in the population, ovarian cancer is something which is rare. In your study group, I'm sure in your hospital, it might be common, but in the general population, it's a rare disease. Cancers happen, maybe 10, 20 people in 1 lakh population. So whenever you want to do or assess risk factors for rare diseases, case control studies are relatively easier because you can include all the individuals with that rare condition, let's say ovarian cancer or cervical cancer, who are coming to your hospital. Then you can choose another group of women who do not have that condition and try to look for exposures in the past. Like you can try to look for, obesity, you can try to look for whether, number of pregnancies or whatever are your exposures that you want to see, or whether there is a family history, etc. So these studies, again, for diseases with long periods of time between exposure and outcome, like specifically for cancers, then these studies are the ones which are usually used. And you can, at the same time, study multiple exposures. Like in the same study, you can see if having a family history is a risk factor, having a particular genetic variant is a risk factor for ovarian cancer. You can look at whether obesity is there. You can look at whether there has been multiple sexual exposure, etc., for cervical cancer. So within the same study, you can look at multiple exposures, which could be risk factors for diseases. The disadvantages, as compared to cohort studies, case control studies have got a lot of biases. There could be a lot of selection bias, information bias. I'm not going into the details, but these designs have a lot of biases. Just to explain, for example, if you are guiding a postgraduate student who's trying to look at risk factors for, let's say, ovarian cancer, you know that obesity is one of the risk factors for ovarian cancer. There have been some reports that, whenever the investigators are asking these questions to ovarian cancer patients, then your PG student might, more likely to ask, have you been eating more fatty foods? Have you been doing less physical activity? Trying to indicate to them what could be the possible exposures for the condition, because they know that these associations exist in literature. So when they frame the questions itself, they will ask those questions in a different way to the people with cancer as compared to the control group, whom they know that they don't have cancer. So probably they have not eaten a lot of fatty foods, or probably they're more physically active, because your investigator is already having these they know these information from literature. So the way they ask these questions will determine how you're going to write the exposure status. So there could be a lot of biases when you do case control study designs. The other major disadvantage with case control study designs is you really cannot establish the sequence of events because you're starting from outcome. Though you're trying your level best to look at etiologically relevant past may whether there is exposure, always sometimes the patient may not remember whether he had been practicing that, whether the person had been smoking in the past, or whether the person was not physically active in the past, or you may not have any documented evidence of these because in India documentation is very poor, even in very good facilities. So understanding the sequence of events and trying to establish this is very difficult with case control study designs. And another problem with these is they cannot be used to assess rare exposures because people may not remember whether they have had a chemical exposure or a radiation exposure, etc. I mean, these sort of exposures, you cannot really study with case control study design. And since we are not having follow-up, you cannot estimate risk, cannot estimate incidence. And since it's not a cross-section, you cannot estimate prevalence as well. So these are some of the disadvantages of case control study designs. Moving to the next group of study designs, which are called as cohort study designs. Now, the take home is you have to remember cohort studies begin with exposure and then you proceed to look at outcome. There could be multiple ways of doing this. It could be a prospective or a retrospective cohort, which we'll come to. So how do prospective cohorts look like? Usually you have a group of individuals who are exposed and a group of individuals who are unexposed. Any group of individuals with a common characteristic, we call them a cohort. So you have an exposed cohort and then you have an unexposed comparison cohort. You follow up both the cohorts over time and you look whether diseases have occurred in this group of people whom you're following up or not. So that is the basic design of a cohort study. Now to take the same example that we have been discussing, you have a group of women under your care, pregnant women who have COVID-19 infection. You have another group of pregnant women without COVID-19 infection. You are giving them care throughout pregnancy, following them up. And at the end, you want to see whether they have had preterm delivery or not. So here, the exposure is COVID-19 infection among the pregnant women and the outcome is preterm delivery. But this is how, if you do the same study as a cohort study, this is how you will do it. So for cohort studies, the measure of association is what we call as risk ratio. Now, arithmetically or calculation-wise, risk ratio is different from odds ratio. How do you calculate risk ratio for the interested group? Risk ratio is nothing but dividing incidence of the people who have preterm delivery, that is the outcome, among the group which is exposed, that is pregnant women with COVID-19 infection. You divide that by incidence of the outcome, that is preterm delivery, among the comparison cohort, that is the women without COVID-19 infection. So the arithmetic calculation is given in this 2x2 table. For those of you who are interested, and if we have time, we can discuss how we calculate this. Now, another group of people might be interested in doing retrospective cohorts. Now, before we go into explanation of what is a retrospective cohort study, when do we usually go for a retrospective cohort? Retrospective cohorts are usually done in settings where you have got good documentation and record keeping. So if you have had electronic health records and databases of these records for several years, then you can easily do a retrospective cohort. You need not wait to prospectively enroll individuals. Okay. For example, today in 2022, let's say I'm in a setup in, let's say, Finland. I've got very good documentation, very good record keeping, electronic records. I make a study protocol and I'm interested in the same question, like whether COVID-19 infection was associated with preterm delivery or not. But the research question has occurred to me only today and not many cases are there right now. So what do? I know that I've got very good records. So I go back in time to 2020 and I take all the women who have come to my hospital with a registered pregnancy since 2020, right up to 2022. And I enroll all of those women who have COVID-19 infection and those who do not have COVID-19 infection. I pull out all their electronic records and I form two groups, women with COVID-19 infection and women without COVID-19 infection. And because I have electronic health records, I have data about each follow-up visit. I also have data what happened to them at the time of delivery. So I'll follow up them through the electronic records and see how many of these women have had preterm birth and how many of them have had term birth. And if I do this, still it is a cohort because I am going from people who have had COVID-19 infection and pregnant women without COVID-19 infection. Through their records, I'm trying to see and follow them up and trying and seeing what was their outcome at the time of delivery. So this again is a cohort where you begin with a group which is exposed, group which is unexposed, follow them up over time and look for occurrence of disease. But here, I'm having the study protocol only in 2022, and I'm able to do this retrospectively because I'm having very good health record system. So this is what is called as a retrospective cohort. Why do I call it as a cohort? My mantra to you is look at the direction of inquiry. Here, the direction of inquiry is from exposure to disease. That's why I call it as a cohort study. And precisely when a lot of retrospective cohort studies are coming up these days, because a lot of the hospitals have got registries, and these registries systematically document, individuals with chronic conditions and keep understanding what happens to them over time. So you've got a lot of retrospective cohorts in literature now. And that's why we have dropped using the term retrospective study for case control. So I urge you not to use retrospective study for case control. And whenever you write study design as part of your manuscript or publication, do describe how you have done it. Who are the group of individuals whom you have included in the study, whether they are exposed, unexposed, or those with outcome, without outcome. What have you done? Have you gone in the past and asked for exposure, or have you gone into the future and looked at outcome? And then so the readers, everyone knows, everyone is the same page, whether it's a case control or a cohort study. So what are the advantages of cohort study designs? Cohort study is a very good study where there is no reverse causality. You have followed up this group of women with COVID-19 infection throughout their pregnancy, and you have seen whether they have had preterm delivery or not. So the sequence of events is very clear. So temporal association can be clearly established. Therefore, there is no doubt, there is no problem. So you can establish reverse causality. Biases are very less as compared to case control studies. And in this particular thing, you can look at more than one outcome. So in COVID-19 infection, you can look at an outcome of preterm delivery. You can look at an outcome of small for gestational baby. You can look for an outcome of congenital anomaly. You can look for an outcome of stillbirth. So many outcomes you can study in the same group of people. So that is another advantage in cohort studies. Rare exposure groups also, you can say, like suppose you have a group which has been exposed to radiological exposure, and then you want to follow up those women to see if there is occurrence of some cancer, etc., then you can still do this in this type of study design. What are the disadvantages of cohort study designs? These take long time. Cohort studies, in an obstetric cohort, of course, the follow-up is 9 months. But you keep on enrolling women for several years, then you always have to follow up those women for 9 to 10 months. Whereas in gynecological studies, maybe an exposure like smoking or something can lead to cancer after so many years, or a radiological exposure and then or a chemical exposure and then some outcome many years. So you may have to spend a lot of time and energy, and you need to have a lot of staff and funding for doing prospective cohorts. And they are really inefficient for rare diseases. If it is a rare disease, always go for case control, because you can easily select a group of people with the rare condition coming to your hospital, compare them with a group of people who do not have that condition, look for exposures in the past. And you can only do retrospective cohort studies or historical cohort studies if your record keeping is excellent. If your record keeping is not excellent, whether it's paper-based or electronic, it's very difficult to do retrospective cohorts. And there are some studies like, when you look at smoking in association with some cancer, people may stop smoking in between. So exposure status may change during the study. And now we do have good statistical techniques to take care of those. But then these were historically considered as disadvantages of cohort studies. And of course, while you're following up women, some of the women may go to some other facility for care. They may go to some other place for delivery. And so you may not always have information about the outcome variable. So this is what we technically call as loss to follow. So when you're following up a group of women with COVID-19 infection during pregnancy, before they deliver, they might go to another facility or they may go to their mother's place for delivery, and you may not know what is the outcome. So loss to follow up can also introduce some bias in how you interpret your results. So that covers cohort studies. So my key take home for you, when you have any confusion about case control or cohort, look at the direction of inquiry. Are we starting with the outcome and looking for exposure? Then it's case control. If we are starting with exposure, looking for outcome, then you're doing a cohort. Cohort study always involves follow-up. So these are some key tips in understanding what type of study design you're reading about when you're looking at literature. Another important thing that I want to share with you is, this is something called as the Equator Network. I've shared the link, www.equatornetwork.org. And in this particular website, you do have links to almost all the reporting guidelines for major study types. So suppose if you're doing an observational study design and you've completed your study, you want to write it up. You want some reference as to how you want to write it up. Especially if you're an early career researcher, then that guidelines is called as probe guidelines, which is nothing but strengthening the reporting of observational studies. And the links to the checklist, the links to the detailed explanation of what these guidelines say is available in the Equator Network. Similarly, for many other type of study designs, you've got the consort guidelines for clinical trials, you've got PRISMA, you've got various other guidelines, and all the links are available in one place, which is called as equatornetwork.org. Very useful for early career researchers who are writing up their study results and into a manuscript. So how do you really choose a study design for a particular research question? You always look at the objective and you understand whether it's going to be descriptive or objective or analytical objective. Also, some of the other considerations are your resources, whether you've got enough money to do a cohort study. Is it better to do a case control with smaller amount of money? Do you have enough manpower to follow up that cohort, document all the events over years? Do you have enough time, with you to do this sort of study? So these are some of the considerations that help you, because for a similar research question, you can do various types of studies. But how do you choose? Like, this is some of the questions that we get from early career researchers. Now, I can also do a case control. I can also do a cohort. So we have tried to list some of the advantages, disadvantages of each design. But primarily when it comes to choosing a design, I feel that you need to look at your available resources and also your objectives. And then you choose which study design to do. So whether it's a descriptive or an analytical objective, that's the first thing that you need to see. And then you need to look at what direction of inquiry you want to do, what are the resources, and then go for which study design. So with that, I've got a few questions. So because I think my time is about to end, I've got some 5 questions, which are 5 scenarios, and I want you to tell me what type of study design was used by the investigators for those scenarios. Is that okay? So let's begin with the first question. An investigator enrolled 200 antenatal women in 3rd trimester to assess the prevalence of anemia in pregnancy. So what the investigator is doing is enrolling a group of antenatal women in their 3rd trimester and seeing how many of them had anemia. So what type of study design is this? Is it a case report, cross-sectional study, case control, or cohort? So some quick answers in the chat box, please. Okay. I'm getting mixed answers. Some are saying cross-sectional. There is one case control. There is one cohort. There is another cross-sectional. Okay. So the correct answer, should I wait for more responses? Okay, we're getting another person saying cross-sectional. One more case control, mostly cross-sectional. So mostly we are happy. So to the people who have said case control and cohort, I mean, if you look at this particular study, the investigator has gone to a group of women and has just measured hemoglobin level and seen what is the burden of anemia. So at one point, a snapshot during pregnancy, gone in the third trimester, surveyed 200 antenatal women, at one point looked at one outcome, prevalence of anemia. So this is what we have discussed as cross-sectional study design, otherwise called as prevalence studies. So most of you have answered correctly. So this is a cross-sectional study design. Now moving on to the second scenario. An investigator enrolled 200 women with incarcerated uterus and another group of 400 antenatal women without incarcerated uterus. The investigator followed them up and recorded incidents of preterm delivery in each group. Can you tell what is the type of study design that the investigator has used? Again, the same answers: case report, cross-sectional, case control, cohort. So I repeat, investigator has enrolled a group of people with incarcerated uterus, a group of antenatal women without incarcerated uterus. He's followed them up over time and has recorded whether preterm deliveries happened or not. What are the answers we are getting? We are getting mix of case control, cohort, and towards the end, we are getting more cohort. Very good, very happy. Towards the end, we are getting more cohort. So what are some of the key things whenever you're confused whether it's a case control or a cohort? What did we begin with? So basically in this, the research question is incarcerated uterus associated with, is incarcerated uterus during pregnancy associated with preterm delivery? So the outcome we are looking at is preterm delivery. The exposure that we are looking at is incarcerated uterus during pregnancy. So what did we do? We take a group of women with incarcerated uterus and we took another group of women with, excuse me for a moment. We took one group of women with incarcerated uterus, which is nothing but the exposed group. We took another woman without incarcerated uterus, which is the non-exposed cohort. And then we followed them up, the keyword, and then we are looking for incidence of preterm delivery. So this is a typical example of a cohort study design. Now let's go to the third scenario. In the third scenario, we are looking at an investigator who has enrolled 100 adolescents with PCOD and 100 adolescents without PCOD. Then she went through the school health records and documented whether they had early childhood obesity. She was interested to study if early childhood obesity was associated with PCOD. What is the type of study design? So, what has happened in this? A person wants to look at whether early childhood obesity is associated with PCOD. She'd looked at 100 adolescents with PCOD, 100 without PCOD, and documenting obesity through records. Excellent. A lot of the answers are case control. Very happy. Very good. Excellent. So the next scenario that we want to see is an investigator surveyed adolescents and assessed if they had PCOD. She also measured the weight and calculated BMI. She was interested to study if obesity was associated with PCOD. What type of study design is this? So the investigator wants to see if obesity is associated with PCOD, did a survey in adolescents, looked whether they had PCOD or not. She also measured weight. Very good. One person is saying cross-sectional, one person is saying case control. Can we have more answers? Very good, very good. Now several people are saying cross-sectional. Now, how did we identify? The person has visited the group only one time. There has been no follow-up. At the same time, the investigator has looked for the outcome, which is PCOD, and she has also measured weight, which is the exposure, and she's trying to look for association. So this is an analytical cross-sectional study design. Very good. Excellent. Final question to all of you. The authors in a particular manuscript described a case of invasive mole following term pregnancy after assisted reproductive technology. They described how the case was managed successfully without distance spread. So what is this type of design which the authors have used for this manuscript? Is it a case report, a cross-sectional descriptor? Is it a case control or a cohort? Case report. Okay, excellent. Several people are saying case report, extraordinary. I'm very happy. So those are the questions that I have. So to summarize my talk, today we discussed about what is the meaning of an exposure variable and outcome variable. We talked about broadly how epidemiological study designs are divided into observational and interventional. The focus of our lecture was observational study designs. Within observational study designs, you have a group of studies called as descriptive, where the authors or the researchers merely want to describe the natural course of events. They do not want to, test any hypotheses, or they do not want to, intervene. Analytical observational study designs are those where we test hypotheses, and to differentiate between case control and cohort, you need to look at direction of inquiry. We also looked at some of the major strengths and weaknesses of each study. So that is the summary of my talk. To end, I thank everyone at FOGSI, ICOG, and JOGI for giving me this opportunity. Special thanks to Dr. Radhika ma'am for inviting me. I would also like to thank Dr. Prabdeep Kaur, my division head, who connected me with Dr. Radhika. And I also thank Dr. Quincy, who's our consultant, who's helped me with the slides. So thank you, everyone, and open to questions if we have time. Over to the chairpersons and the moderators. Thank you.
Thank you, Dr. Archana. I think you have told in the very simple way and very good way. I think इससे अच्छा नहीं हो सकता था. Students has learned a lot and they're very interesting. So this is the very important aspects of studies, then how it should be started, how you have to do according to the questions. You have taken the example and cleared it very simply. So thank you very much. I think no questions in the chat box. If other chairpersons are there, they can give a comment.
Yeah,
There are
so
no questions. I request Dr. Surya to please give her first comment.
yes, so
Jyotika, go ahead.
yeah. So first of all, I want to congratulate FOGSI, ICOG, and JOGI for this wonderful initiative, which is the need of the hour. Everybody has already commented on it. And I want to thank all the organizers, especially Dr. Radhika, for inviting me here this evening. Coming to the talk of Dr. Archana, I don't know what to say. She is an excellent and exceptionally lucid teacher. I think all the responses which have come in the chat box, there are so many of them. Every one of them has appreciated your talk and your answers when those practical questions you have asked, you have got, people have given you correct answers. So that is a full marks to you, Dr. Archana. So it is a very, very clear and absolutely very lucid lecture, I must say. So I don't think people have got much, doubts at all, because you have repeated the important things so many times that I think they will never forget the difference between, a case control or a cohort. You have made it very, very clear. Would you like to comment anything about clinical registries, which are very common nowadays? So so where would you put them? They are also like a cohort only. So how would you put clinical registries?
Thank you so much, ma'am, for those comments, and extremely happy to be here to, come and share whatever little bit of information that we have along with you. And to answer to your question about clinical registries, Clinical registries are nothing but repositories. Suppose if you have a group of individuals with a particular condition, let's say you want to have a repository of women who have underwent ART for infertility, or you want to have a repository of women who have had like cervical cancer, ovarian cancer, etc. So a registry is something where you keep on adding information about all of these individuals, and you can involve multiple hospitals, multiple institutions within that. And over time, you also document what happened to these people, whether they have, if suppose you're looking at a cancer registry, whether after chemotherapy, what is the outcome? So you can define the scope of that registry, and that repository keeps adding this data. So once you have this repository of information, at any given time, a researcher, if he has a pertinent question to that particular related area, let's say cancer or let's say ART, then using that database of information, he or she can test hypotheses, or he or she can, do any sort of research. So registries are coming up in a big way. In India, we do have cancer registries. We do have, CKD registries. I'm sure in gynecology also you would have, there are diabetes registries. So I'm sure there are registries, and many of your early career researchers would find it useful. Yeah. Thank you.
Yeah, thank you very much. So I hand over for the question answers, if there is anything.
Ma'am, there are no question answers.
Yeah.
The topic was so simplified by Dr.
Yeah.
Archana that all our delegates are very clear with the topic, and there are no questions as such in the chat box. So I thank both the chairpersons for conducting this session very well. And as the time is up, we move ahead for the next session. The next session is on qualitative study design.
Vaishali, your volume is too low. Vaishali,
Yes, ma'am.
please speak in the mic.
Yeah. I request Radhika ma'am to call the next chairperson, please, as my voice is not that good.
So, is my slide visible?
No. Yes, no, slides are not visible here.
Not visible yet?
No.
Okay.
Yeah.
Is this okay now?
It's
Yeah.
coming. Yeah, yeah.
Okay.
It's visible. Yeah.
So we quickly move on to the next part of the session. And here we have another very interesting session on the qualitative studies. So we have with us the chairpersons for the session, Dr. Madhu Gupta. She is from PGI Chandigarh. She's a professor in the community medicine and School of Public Health at PGI IMR Chandigarh. And as you can see, she's got lot of experience, lot of awards and accolades to her credit. Warm welcome to you, Dr. Madhu.
Thank
So
you,
we
ma'am.
have with us Dr. Renuka. She's a senior consultant obs and gynae at RML Hospital and Atal Bihari Vajpayee Institute of Medical Sciences. And her special interests include IVF and WHO fellowship in laparoscopy, IVF fellowship from US. She's a dear friend, long years of experience. Very happy to have you here, Renuka. And we have Rimpi. She's an associate professor at PGIMR Chandigarh. And she's a very active, interested young obstetrician, lot of interest in research. Welcome to you, Rimpi. So I request the chairpersons to start the session, please.
Thank you, Dr. Radhika. And I'm really thankful for ICOG for inviting me to chair this session. And I'm also very much interested in qualitative research. So I would like to invite the speaker for this session, and I would like to introduce the speaker first. May I have the slide of the speaker? Thank you. So I would like to invite Dr. Tanu Anand. So Dr. Tanu Anand is the alumnus of Lady Hardinge Medical College. She has a background of community medicine, and she is also did her PhD from MAMC. She has over 10 years of experience in medical education research. Currently, she's working as Scientist D in ICMR. And she had been part of COVID-19 rapid response team of ICMR. So that is very, very prestigious and very good experience. And she's also program officer for epidemiology and surveillance of COVID-19, epidemiological investigations and DHR ICMR schemes of MRU and MRHRUs. and she has over 50 PubMed index publications. So I welcome you, Dr. Tanu Anand, for this session. Thank you.
So I'll stop sharing.
And I would like to thank the organizers, FOGSI, ICOG, and Jogi for inviting me and giving me this opportunity. Am I audible?
Yes, you are.
And are my slides also visible?
Yeah, all well. Tanu, go ahead.
Okay. So I would also like to congratulate speaker Dr. Archana, and it's been pleasure to hear her. She has been my colleague at MAMC as well as now in ICMR. So very enlightened to see her for her lucid talk. I would like to begin my talk on qualitative research with the quotation by Albert Einstein, who said that not everything that can be counted counts, and not everything that counts can be counted. Which underlies the importance of qualitative research, particularly in medicine. And this is an new, I would say, not really new, but new in terms of medical and clinical practice as we go. So as we all know that quantitative research refers to the name refers to that something which can be measurable. So as in the last session, we have heard about when we want to measure the magnitude, extent of the population and various associations, there is where the statistics come into play, and that refers to a quantitative research. Whereas a qualitative research, as the generic name suggests, quality, it measures quality. And in a truth sense, quality goes beyond measurements. So it leads insights into underlying processes and reasons for existence of a particular phenomena. So when we want to study behaviors which are difficult to be measured, though we can measure through certain scales, but not always easy, there lies the importance of qualitative research. So this type of research gives in-depth understanding of human behavior, why there are why certain individuals or groups or communities are behaving in a certain way. So it tries to investigate why and how, whereas quantitative research is limited to what, where, and when, and more of a description and association. So why did it happen in that context? Why do some people participate and others not? And how do professionals, managers exert their power? It emanates from social sciences. Therefore, its practice in health sector has been of recent origin. So giving you an example, if we want to undertake quantitative research of, say, smoking and lung cancer, so we may have an observational study which will try to link, and it's already established, an association between smoking and lung cancer, whereas a qualitative research question would try to explain the power of tobacco companies and advertising, particularly when we try to understand the smoking behavior, reasons why people continue to smoke even when the evidence exists against its healthful impacts. And also, what does social meaning of smoking means for youth and women? Another example could be quality of maternity care. So in quantitative terms, the research question would have a quality of care questionnaire based study where we would try to see if there is a difference or not in terms of quality of maternity care provided by auxiliary nurse midwives when they work in team in primary healthcare settings, or when they work as individuals at the sub-center level. Whereas a qualitative methodology will try to include what constitute quality of care in terms of not only the health professionals, what the ANMs are doing by observing them, but also from the patient's perspective, what does the quality of care is constituted in terms of their perception. So why we are now at this forum discussing about features of qualitative, why we need to do qualitative research, and how does it contribute into this. First of all, important to understand is that unlike quantitative research, which is guided by a hypothesis, there is no hypothesis guiding the researcher here. As I already stated, that this tries to address that why that particular phenomena is occurring. Another important aspect of this type of research is that it concentrates or involves studying only few participants, which could be individuals or communities or even settings. So there is no concept of what you say as a sample size estimation we have to do in terms of qualitative research. Thirdly, there needs to be usually people say that qualitative research lacks scientific rigor because as an individual researcher, when we go with a baggage. So very important point in undertaking a qualitative research is that we have to have a neutrality. We need not, we have to leave our perceptions, biases, opinions when we are going as a researcher into a particular context. And usually here, the phenomena, as I explained in the last example, goes beyond quantity. So we only need to understand not only one aspect, but we have to identify various stakeholders and include various participants into perspective for understanding that particular behavior. And data analysis is interpretive in nature. In clinical practice, the role of qualitative research comes when we are trying to study a new population, say when we want to explore the motherhood experience of adolescents who got married, or it's the intravenous drug users. So such sensitive population, there we have to go beyond medicine and also understand their behavior with respect to the environment in which they live. That includes the social part of it. Or when we are trying to explain a contemporary or a recent phenomena, that despite availability of so many family planning options available, still people are not able to follow proper family planning, or population control is not happening. So we try to understand that phenomena, that despite availability of various choices, cafeteria approach, why people are still not accepting certain forms of family planning. Or when there is a sharpening contrast between different behaviors, and some places there is a good acceptance of vasectomy or tubectomy, whereas in other places there is not, there is a resistance. Why the same particular intervention is being received in different senses. So there comes the role of qualitative research. And as I already stated, when we are trying to probe some sensitive topic, it goes beyond biomedical research, and we have to explore other aspects like sociological, anthropological, and sometimes even economical. So there comes the role of qualitative research. Some of these differences I've already stated, but important points, or what I would say, the take-home message is that the quantitative research is driven by a hypothesis. It assumes that there is existing a single reality, as Archana was stating, that there is a null hypothesis and alternative hypothesis when we do a quantitative research, because it assumes that either of these two will hold true. Whereas in qualitative research, usually there is no single hypothesis, and we have to assume that multiple realities may be existing, and therefore the design is flexible and emergent. It is evolving as we continue to explore further and further. And another important difference in terms of exploration is that there is a fixed sample size for each study design in quantitative research, whereas in qualitative research, there is no fixed sample size, and usually qualitative studies are conducted with a sample size of 12 to 50, depending on the research questions, because our aim is not to have as many people as possible, but to understand the phenomena even in limited population, but whom we have, but we should, when undertaking qualitative research, we should know whom to contact and who could constitute our sample population. So there are two types of study designs as far as the qualitative research goes. One is called as the descriptive or exploratory design, This is the most common design which is adopted by the researchers in particularly in those which are involved in biomedical research. So it is more of describing a particular phenomena, and sometimes you try to see it in the context or setting. So as I stated in the example, that why certain people are accepting one form of family planning method, whereas others are not. It is just trying to explore a particular phenomena. We go deeper, interpretive design. This is having root more on sociological research and anthropological research. It seeks to understand human behavior from perspective, as already stated, in terms of culture, context, societal norms, and beyond it. So these interpretive designs for today's session, I would say, would be difficult to probe, and you will require a kind of a training to undertake such forms of research. And then there is a phenomenology where the researcher tries to explore the real life experiences of individual to explain that particular phenomena. And there is one more design which is called as the grounded theory, which is while collecting the data and analyzing and reanalyzing, the researcher tries to formulate a theory. So these are more of a sociological research. Now coming to the first part, how do we know how many cases or how many samples do we need to have? So as I already stated, we should not concentrate on the number, but our aim is to select information which is information rich cases for studying in depth. And as people can be sampling units, there could be settings or places, events, etc., can act as a sampling unit. So before when we are writing or when we are formulating a protocol, we should try to define our sampling frame. Like suppose I want to study the first-hand experience of married adolescent girls who became mother during adolescence. So my sampling frame would be an adolescent girls in particular community or hospital settings, whatever you have to define. And then I would explain whom all I would try to sample it, like how many adolescent girls I would like to have, say some of those who were of late adolescence, say 17 to 19 or 15 to 13 to 15, something like that. And then explore their experience of motherhood at young age. Also, it is important that these are some of other sampling principles that one has to undertake, but that also depends on what your research question is and what methods you are following. So when you are trying to take interviews, which are one-to-one interviews or in-depth interviews, it is always suggested that your sample that you are selecting should have wide variations in the experience. So comparing people who accessed healthcare versus those who did not. And so you can have among the people you are doing in the hospital, or this kind of question would be more suitable in community when you go and you are seeing that why people are not seeking antenatal care. So some of the pregnant mothers could be interviewed, and those who are seeking care could also be included. And we say that we will include the sample taking maximum variation, and we will continue to have the sample till saturation is achieved. So what do we understand by saturation? Saturation means when no new information you are gathering on repeated interviews. So this is another feature that guides that there is no fixed sample size, but you continue to interview or select cases till you achieve saturation. Usually in a qualitative study which is based on in-depth interviews, about 10 to 12 interviews are sufficient. But again, it is an iterative process. As a part of methodology, one has to write that we would continue to select the cases and interview till the saturation is achieved. Second is sampling is especially when we are using a method of focus group discussions. So in case of focus group discussion, as the name suggests, there will be a group of people who would be selected. And in usually FGDs, we try to select a sample which is homogeneous. So they would be able to describe the experience or process in a better way. So very commonly we conduct FGDs about, say, if we want to know that what is the perceptions or practices women usually follow towards illegal abortions. So we would like to have these FGDs among women of reproductive age group 1 or 2 FGDs, and we would also like to have another FGDs among the in-laws, like mother-in-laws, because sometimes this kind of behavior is forced upon in the family settings. But the group that we are selecting at a time should be homogeneous. So we may have separate FGDs for mother-in-laws and for the women in reproductive age groups, but within that group they should be homogeneous. Then there could also be a sampling on the basis of a criterion which we may select, that all cases meet a set of criteria. Examples, suppose we want to assess like how their aftercare program has been once they have been discharged from ICU. So we may describe that all our cases that we would select would be former patients who were selected, who were admitted in ICU, and now we want to see their perception and how they feel the aftercare program has been. Qualitative research can be done as a standalone research as well, but usually in biomedical field nowadays we try to do kind of a mixed method study where quantitative research is followed by a qualitative research, or sometimes a qualitative research usually guides in quantitative. So when we are trying to validate some questionnaires, or when we are trying to develop some intervention, a qualitative research precedes a quantitative research. And it could be other way around, that we have done a survey, something like NFHS that we do after 3 to 4 years periodically, and every NFHS depicts the state of maternal and child health, and then based on what has been the practices with respect to antenatal care, postnatal care, we may try to explore why, despite having our iron supplementation program for last 50 years, why anemia still continues to be a problem in a subset of population of women in reproductive age group in a selected district. So this kind of mixed method design is done, and this is called as the triangulation, because we are trying to use a different strategies within within qualitative aspect also, as well as quantitative. Now what are different types of sampling types? So up till now what we have learned is about the sampling principles that we have to follow depending on the methods we choose to undertake a qualitative research. Now, what are the various sampling techniques? One is called as the purposive sampling. As the name suggests itself, that purposive sampling means that it should serve a particular purpose. And therefore, we have to select individuals who are going to satisfy that purpose. So example is, we want to understand the infant and young child feeding practices at birth in the family settings. So we want to select, our purpose would be solved when we either interview mothers and or mother-in-laws, or even the mother's mother, for understanding, because family influences also the infant and young child feeding practices, as the literature suggests. So it is very important that we, when we are very sure that who our cases or sample would be satisfying that particular purpose. Then is the quota sampling. Again, as the name suggests, it is based on certain characteristics we are going to do sampling. That characteristics could be the demographic characteristics like age, place of residence, gender, class, profession or marital status, or it could also be geographic locations, culture like tribal populations, etc. So, and here, if our research question is that we are trying to explore perspectives of patients and healthcare providers in use and access to injectable contraceptives, we would like to conduct in-depth interviews among females of 10 to 12 females aged 21 to 35 years or 5 healthcare providers. Here, I would like to state that when we are writing a protocol for this kind of research study, particularly qualitative, as I said, usually our main aim is not the number of samples that we are taking, and usually it is 10 to 12, at the most 20 would satisfy, but there is not fixed number which would state. So it is always convenient to state that we would continue to collect the cases till saturation is achieved. Okay, here I have specified because I wanted to depict the quota, like for 5 healthcare providers based on their occupation, I have fixed a quota of sample, and based on the other demography, that is population, I have fixed a quota of 10 to 12 females. Then there is a technique called as a snowball sampling. So here, also known as a chain referral sampling. So one respondent you select, and from that respondents known to, you try to approach other people. And this is particularly common in diseases where there is a lot of stigma attached. So HIV/AIDS, when we try to see or assess the behaviors in people living with HIV/AIDS or their family members, usually this snowball sampling technique is used. And many a times, a lot of RTIs, STIs studies on qualitative research also employs snowball sampling. So from one client, we get to contact other, and those who consent to participate, usually such sociological studies are taken. Then there are other forms of sampling also called as opportunistic sampling, which is taking advantage of on-the-spot opportunities. So for example, if you want to study, say, patients who have suffered heart attacks, and you are going to visit a cardiology department, that would be an opportunity. And from there, you are going to select the patient. So that makes it an opportunistic. Similarly, if a patient is visiting for healthcare seeking at your settings, and you want to assess, say a woman has come to a gynae OPD for, say, some gynecological consultation, but you want to assess, say, some their behavior for particularly with respect to nutrition. So you take this opportunity of using the clients that are visiting your hospital for understanding for research purposes. I think somebody has raised hand.
I think I can complete your talk, Tanu, then we can address the questions.
Okay, ma'am. So then is the convenience sampling. This is the most common sampling strategy which we usually find in protocols because it is the easiest of all. As the name suggests, it is on the basis of convenience. Whomsoever we know and convenient to approach, we try to contact them. But it is considered least desirable because, first of all, it introduces bias, and secondly, it does not assure, like what I was explaining you about, maximum variation. So of course, for FGDs, it would be easier, but again, it would not be representing the true picture. So it is always better that we try to avoid this form of sampling. And then there is another form of sampling called as volunteer. So we try to advertise or send emails and requesting people to volunteer to participate in the study. And here then the volunteer sample of people are taken. Again, I have put these three as separate because these this introduce some form of bias and may not actually explain the phenomena. So only who desired, there could be various reasons for people to volunteer, and there could be various reasons from the researcher point of view also, if they are conveniently choosing the sample. So the previous sampling ensures variation and introduces more rigor to the qualitative study. So as I said, sample size I've already talked about. Important point from here is that sampling should be terminated when no new information is forthcoming from the sampled units. There are some ethical principles which we need to follow. Of course, because these the conduct of qualitative research involves a lot of deep contact of the researcher with the participants. So important to assure confidentiality as well as respondent welfare, because we are trying to go into their settings, we are going to assess their beliefs, so therefore that should always be taken into account. Particularly, we also say that when we are conducting in-depth interviews, of course, we introduce ourselves and then we ask their names and other identifiers that should not be documented. And even when we are writing a paper and explaining the quotes, so in that case, we try to assure as much confidentiality, but sometimes that is breached, particularly when we are interviewing the health professionals in, say, particular state, say state program officer of RM and CH plus, say, in a following state. If we mention that in paper, it obviously there is only one person, and that time confidentiality could be breached. So it is, we should have mechanisms by which we could ensure that confidentiality does not happen. And of course, legal and moral standards need to be followed. And it is important that in qualitative research, the participants become the part of the research process. As I said, there is a more deeper connection with the participants when we are conducting the qualitative research. So we have to be very sensitive. At times, people break down, particularly when we are trying to explore on sensitive tissues, sensitive issues. And therefore, it is important that we take into account all this. And therefore, training on qualitative research methods is very important. Now, data collection methods, as I already said, a few of them I discussed previously. There are interviews, there is a discussion which we can do. We can also do document review. So we can verify, assess whether we need to interview based on the audit reports of, say, if we want to see the nursing practices. As soon as the baby is delivered, we want to see how the nursing care gets instituted. So we may see the various reports and charts, and then we can interview the nursing staff about it, and also observe their practices soon after birth. And of course, observation, it gives a first-hand experience. We can also use a checklist, or we can just make a note. And important in qualitative research, the non-verbal communication also needs to be documented. Therefore, it is always better that we go into the settings and have more of a, say, rapport building and ice breaking before we actually start the research process. So these are the qualitative study methods. Case study. So case study here means, unlike in quantitative research, here we are using this term of case study as a social unit. And this social unit can vary from a unit as a person to entire community as well. And its aim is to determine the factors that account for complex behavior patterns of the unit and the relationships of the units to its surrounding environment. You will get more clarity in some of the qualitative researchers also consider case study to be beyond methods. It is considered as an approach because it includes a variety of sub methods. You can say it involves interviews, it involves document review, it also involves observation. So an example could be that there was one study which was done in UK where the nurses' practices were assessed how they manage pain in pediatric population. And this was a case study to demonstrate the nurses' pediatric pain management practices in NHS, and it included observational data, a questionnaire data to explore theoretical knowledge, and also a questionnaire of how critical nurses perceived pain management tasks to be. And the findings were that their theoretical knowledge did not correlate with the impact practices. Also, their perception certain that how critical it is to manage pain in certain pediatric conditions did not actually impact their practices. And there was a discordance between a self-reported and actually observed practices. So it's a mixed method study which used both quantitative and qualitative methods. Important is that how this became a case study, because we want to see uniqueness. So we usually select a case basically on the uniqueness. In quantitative research also, our case report or a case series becomes when we see a unique case which has not been reported or some unique clinical finding in a particular case. Similarly, in qualitative research, a setting or a group of individuals or even a single individual behaving in a way which is not as per the norm in particular health condition constitutes a case study. Another example of a case study is about the introduction of electronic medical record system in selected areas in UK, where they had taken 5 hospitals as their case studies, and they conducted semi-structured interviews with the health managers as well as with the other staff and patients. They visited, documented the data with respect to the EMR that was first piloted in these 5 hospitals. So the findings were that the implementation was more slow than envisaged. Upon interviewing the health staff and the managers, it was found that it was mostly forced upon by the government and prevented flexibility. So it did not take into account the local prevalent conditions. It had same kind of record form for all the 5 hospitals, though there were many conditions which were very unique to certain areas. So that was missed upon. And also, based on the interviews, it was also found out that the government was pushing for an ambitious and unrealistic timelines, which led to frustration among not only the developers, but implementers as well as health professionals and managers. So from this, we actually come to know that our system that we are trying to envisage requires some form of modification, and therefore such helps to improve the operations in the service delivery. So advantages of case studies that it provides a detailed in-depth description of individual case, and as it employs multiple methods together, therefore it is considered to be a kind of more comprehensive experience of a phenomena. And as I said, it includes both qualitative as well as quantitative evidence. But important limitation of this is that a single case study may or may not be representative of a large population. And it is also very important that whom do you consider as a case. So that selection is also very important. Otherwise, your data or the information that you are collecting may become erroneous. Of course, it requires a rigorous form of experience in actually considering what constitutes a case study. and therefore we need to have more of a literature review, more aware about the settings in which we are working to actually follow this form of methods. The less I would say, as compared to case study, the more commonly employed methods is about in-depth interview. And as it says, as the name suggests, it requires kind of deeper interaction between the interviewer and the respondents. And of course, you have to follow a good technique of interviewing. After taking informed consent, you have to be more active listener. An important characteristic of qualitative research is also that you should not ask leading questions like yes or no, and let the participants speak more than you. So you should be a good listener. And while you are interviewing, as I said, you should also document the non-verbal communications, or the body language, the way the person is dressed up should also be documented in your field notes.
Dr. Tanu, I think we are nearing time also. Just
Yes,
take care of that. Thank you.
Yes, ma'am. As I said, you should not, you should also follow strict neutrality and emotional support, particularly when the interview is about a difficult topic. And it is always better that you should be accompanied by another person, and the notes could be taken by both of you, so that if one person misses, the other person's note could also be combined. And this is usually conducted using an interview guide, which is not structured like questions like what is your age, what is your name, but it consists of various probes, that why are you coming to this health facility, who all were the sources of information for making you aware about this facility, when you first visited, what was your first reaction, how much was your waiting time. So such kind of probes should be there. Theme list refers to important topics that you are going to cover when you are conducting your interview. So example is that again, this was one study which wanted to explore an impact of operative delivery in the second stage of labor. And here the findings, it was an in-depth interview with the women who were in another quantitative study as a part of a cohort, who delivered between 24 to 36 weeks. And then they were asked about what was their perception. So most of the women felt that they were unprepared for operative delivery. They emphasized the importance of maintaining an open mind about the management of labor, which was never told to them or counseled during the antenatal care. They had difficulty understanding the need for operative delivery, and that also left a noticeable impact on women's view about future pregnancy and delivery. Again, another example is about choice and birth method, and this refers to an elective cesarean, which is common in Western countries. So many women support the principle of choice. So it was asked and they were explored that why would you like to go for elective cesarean delivery, and what actually happened when you delivered. So what mode of delivery was followed? So most of the women said that their autonomy was limited by individual circumstances and available care provision at the time of delivery, though they had opted for an elective cesarean as a during their first delivery, but they were not given the choice when they delivered. And there were other findings also which represented women's perception regarding the choice and birth method. This is a focus group discussion, and it requires that there is a situation in which participants, usually of same, as I said, homogeneous group of people should be there, and they should be under the guidance of a facilitator. Here also, the role of the facilitator or a moderator is just to steer the discussions, but the moderator should not lead it. So let the participants only speak. The number for such kind of discussions is usually limited to 6 to 10, and duration can range from 1 to 2 hours. So it also requires an interview guide, which is not a structured like questionnaire, but just important topics which one is going to cover during those discussions. And it requires a moderator guiding the discussion, and there should be one who is taking the notes of the discussion as well as non-verbal aspects of the group. So these are the teams. Advantages that it allows in-depth knowledge very quickly. It is very cost effective. Usually sensitive issues are discussed in a group, but the disadvantages could be that in a group, some people may dominate while the others not. So it is the role of the moderator to actually see that he or she is able to steer the discussion well. Lastly, this method is ethnography. And this I would not discuss much because, as I said, this roots from anthropology and sociological aspects, and it requires deeper understanding of the context. So the researcher actually gets into the social setting, gets involved with the participants, lives with them, observes them, and documents his or her observation. So this one's just example I just want to discuss, that this was a maternity care in British hospital where they observed midwives behavior towards different set of people, and the findings were that the midwife stereotypes of South Asian descent maternity patients were ill treated. They considered their origin or racial origin as a way of providing care. So that resulted in inequality of health experiences by Black and minority ethnic patients. Briefly, about the qualitative data analysis. Qualitative data analysis lays the foundation lays on how you have documented the entire discussions or the interviews that you have taken. It is always recommended that whenever you are conducting an in-depth interview or a focus group discussion, you go back and just reflect upon the information that has been collected and try to write a transcription of what has been there. Nowadays, we also have audio recorder, so that helps. You can record after taking due consent for audio recording and just make the transcription of the entire interview in the verbatim in which the patient has or the participant has spoken. After which, if it is in local languages, it needs to be translated into English. So this process usually takes about 2 to 3 days. So you have to have numerous rounds of reflection, rephrasing, and analysis. And after the translated version is ready, then comes reading and rereading, multiple readings of the translated interviews or discussions that has happened. And then you try to code. So what is the code? I just give you an example. So this is one question. In your opinion, who are the people that generally do not bring their children for polio drops on national immunization days? So this is what the respondent has said. And sometimes it happens that parents are unaware of it or neglect it, or there are some parents who do not give importance to it, or they go outstation. Till now, they have understood the importance of drops and that it should be given. So I'm reading till here. The lines that have been marked actually give out some message that there is an unawareness on the part of the patient parents. There is also a neglect. Also, less importance is being given, or people are traveling because of which they are not able to access this immunization service. So some kind of factors are emerging out of it. So we try to, from the transcript that we have translated, we try to find out the factors of particular importance to our research questions. In this case, I have tried to enlist certain factors which have emerged out from this interview, and based on we can give them numbers here. here if we have we will be having a set of say 10 to 12 interviews, and from there these domains have come. So based on these domains, I have found out, say, superstitious people who say it is all in hand of our Almighty has come from this code. Non-believers, non-faith believers of other systems, superstitions. So from there I coded it as 7. So this way, once we code, we try to combine the codes, and then that comes as a subtopics, which is going to achieve our objectives for qualitative research. Lastly, I'm going to talk about these guidelines. As Dr. Archana had already stated, you can go to Equator Network to find out the reporting guidelines for most of the studies. So similarly, you can find the correct guidelines, which is the consolidated guidelines on reporting of qualitative research, primarily for in-depth interviews and focus group discussions. It is a 32-item checklist which covers various aspects, and one while writing the paper as well as protocol, one has to take into account these characteristics. Lastly, now, which approach should we follow, qualitative or quantitative? So as I started off, that when we want to measure how many and how much, we go towards the right side of the x-axis, but when we have to understand why and how it is happening, it is better that we employ a qualitative approach. And as we move up towards the left hand side, it usually explains the behavior. The quantitative and qualitative research are not enemies. They are in fact complementary. If employed in a proper way, they can put the analysis into perspective and give us a deeper understanding of certain behaviors that one is following. So I would like to end. I'm sorry I had to rush through these slides, but you can ask any questions if there are.
Yes, Dr. Tanu very well said that while the quantitative studies are looking at the numbers, the qualitative studies, they look at how and why. I would say they really give a meaning to those figures. And in this short period of time, Dr. Tanu, you have really elaborately described the essence of qualitative studies. And I would really congratulate you for that. And thank you for such an enlightening talk. And I would also like to thank ICOG and FOGSI for having me here as a chairperson. And I would invite my co-chair, Dr. Renuka, for her expert comments, ma'am.
Dr. Renuka, you are muted.
Ma'am, you are muted. Please unmute.
No.
You have to unmute. Now it's better, yeah. This is a wonderful initiative by Team ICOG. Research methodology has become the need of an hour, especially now those MDs it's compulsory for them to publish 2 papers at least. So this will go a great way. This concept is excellent. I congratulate everybody, and especially I thank Dr. Radhika. She's my close friend, and I know she not only puts her heart and mind to everything, she also puts her soul. So this webinar series is going to be really good.
Thank you so much. Renuka, would you also ask, would you like to have any clarifications done by Tanu? I don't think there are any questions here.
Tanu has given such a descriptive talk.
I think we would want a separate session for qualitative studies. Like you can see, Tanu, we are very familiar with the quantitative studies. So qualitative is one thing in which we would certainly like to learn a little more. And you had short time, and in that span, I think you did a very good job. So thank you so much. I agree with all the chairpersons. Thank you so much for the chairpersons for being here, for taking out your time. Dr. Madhu, Rimpi, Dr. Renuka, thank you so much. So, can we now have the vote of thanks by Dr. Ranjana, please?
Thank you, madam, and good evening to all. Teamwork makes the dream work. And that is what has been proved by the FOGSI ICOG Jogi team led by none other than ICOG Chair Dr. Lakshmi Shikhande ma'am, FOGSI President, Dr. Hrishikesh Pai, Vice President, ICOG, Dr. Parag Biniwale, Secretary General FOGSI, Dr. Madhuri Patel, ma'am, ICOG Secretary, Dr. Ashok Kumar, sir, Editor-in-Chief Jogi, Dr. Geeta Balsarkar, and Editor Emeritus Jogi, Dr. Suvarna Khadilkar, ma'am, and executed in most perfect manner by our dynamic and meticulous convener, Dr. A.G. Radhika, ma'am. I express my gratitude to all of you, the stalwarts of FOGSI ICOG, for initiating this research methodology webinar series. And my sincere thanks to the two wonderful, brilliant speakers, Dr. Archana and Dr. Tanu, for their very informative and lucid presentation. And to our esteemed chairpersons, Dr. Bharti Maheshwari, Dr. Jyotsna Suri, Dr. Madhu Gupta, Dr. Renuka Malik, and Dr. Rimpi Singla. My heartfelt thanks to Dr. Vaishali, who coordinated today's webinar so well. A big thanks to Nilima and Mr. Jignesh for all the hard work behind the scene. I'm sure the participants must have greatly benefited. Thank you all for logging in. So goodbye till we meet again on 20th January 2023.
Yes. So
thank you very much.
we have shifted the dates because of AICOG. So kindly note the change in date. We are meeting on 20th January as already announced by Dr. Anjana Sinha. So looking forward to meet you all again on 20th.
So thank you very much. Thank you, Dr. Lakshmi Shikhande, for giving us this opportunity. Thank you, Dr. Ranjana, Dr. Vaishali, for being the pillars of support for the program. So good evening all. See you again. Thank you so much.
Bye.